Comparison of ORISE Gel, hyaluronate solution, and saline as lifting agents for ESD in an ex vivo bovine model. This investigator-initiated study was supported with the gel product and a research grant from the Boston Scientific Corporation. Endoscopic submucosal dissection is the gold standard treatment for large sessile colon polyps. The goal is en-bloc excision in the submucosal plane with negative margins. Further goals are low rates of perforation, bleeding, and recurrence, as well as avoidance of colectomy. Of note, for superficial cancers, en-bloc removal with clear margins constitutes definitive treatment. Critical to ESD is a successful bowel wall injection that expands the submucosal layer, which is the resection plane. Expansion of the submucosa decreases the chances of perforation by increasing the distance between the polyp and the muscularis propria and serosa. The duration of the mucosal lift is a critical variable. Lifts decrease with time. Also, incision and dissection accelerates lift decay. Therefore, periodically, the lift needs to be refreshed. To do so with a standard sclerotherapy needle, the knife needs to be removed and the sclerotherapy needle inserted. After making the injection, the instruments are switched again. This instrument exchange adds time to the case and wastes the peak lift period. A variety of lifting agents have been used. Currently, the most widely used agents are Eleview, hyaluronate solution, and ORISE Gel. The gold standard worldwide is hyaluronate. The commercial product is not FDA approved, and thus hyaluronate has not been used in the U.S. ORISE Gel is a new product that has become the first choice for many endoscopists. This study's purpose was to compare hyaluronate, ORISE Gel, and saline as ESD lifting agents in an ex vivo bovine colorectal model. Intact large bowel was obtained and mechanically cleansed and instilled with antibiotics and antiproteases. After drainage, the colons were stored at -80 degrees Celsius. Prior to use, the colons were thawed slowly. Then a colotomy was made, through which 3 lesions were branded onto the mucosal surface using a circular wire with a 2-centimeter diameter. The lesions were located 35, 30, and 25 centimeters from the anus. The colotomy was then suture closed. The bovine colon was then anchored to a pegboard with the polyps in the up position. The colon's proximal end was clamped and a cautery pad wrapped around the colon. A sclerotherapy needle was used to generate the lifts. For a given colon, a different lift solution was used for each lesion. The lift solutions used for the proximal, middle, and distal locations was varied from colon to colon. An Olympus dual knife was used for all cases. A pediatric colonoscope with a dissection cap on its tip is used. The outline of the disc to be excised is marked with superficial burns, after which a lift is established. Next, 15 to 20% of the mucosa is incised, after which the cut edge is undermined with the knife. Next, the cap is used to expose and cut the adjacent submucosal attachments. Periodically, the lift is refreshed, after which the mucosal incision is extended and the process repeated until the lesion is detached en bloc. The parameters tracked were case length, completeness of resection, number of instrument exchanges made to refresh the lift, volume of lift solution needed, and number of deep wall injuries and perforations. After practice cases on 2 colons to work out the logistics, the study was done using 18 colons. All cases were videotaped. The lifting agent used at each location was varied. A single surgeon did all of the cases. It was noted that tissue quality was generally better at the distal location. The results for the 3 lifting agents were compared using the Wilcoxon signed rank test. The resection line was first marked with superficial spot burns. Next, the lift injection is made. It is critical that a superficial lift be made by injecting the submucosal layer. A proper lift is round and tall, and the dye color is clearly seen. Next, the mucosa is scored with the needle knife for 10 to 20% of the circumference. The cut edge is next undermined with the needle knife to create a ledge. The cut mucosal edge is then retracted with a dissection cap, which exposes and stretches the submucosal fibers. The process is repeated, lift, score, undermine, detach, until the excision is completed. The resected pelts and the bowel wall defects were photographed and assessed closely. Results: complete en bloc resections were done in all cases. Rents in the pelt were noted in 28% of saline cases, 22% of hyaluronate cases, and 17% of ORISE Gel cases. Also, full-thickness perforations were noted in 3 of 18 saline group cases, while none were noted in the gel or the hyaluronate groups. As regards these parameters, there were no significant differences between the groups. The median rate of deep injuries to the muscularis propria was 3.5 to 6.5 per case. The injury rate was significantly higher for the saline group when compared to either the hyaluronate or the gel groups. There was no difference noted between the gel and hyaluronate groups. The median case length was 42 minutes for the saline group, 37.8 minutes for the hyaluronate group, and 34.5 minutes for the ORISE Gel group. Both the hyaluronate and gel group case times were significantly shorter when compared to the saline group. There were no significant differences noted between the hyaluronate and the ORISE Gel group results. As regards the median volume of lift solution used per case, the saline group required 78.5 mLs, the gel group 43.5 mLs, and the hyaluronate group 37.8 mLs per case. Significantly more volume was needed for the saline group cases when compared to the other groups' results. No significant difference was noted between the hyaluronate and gel groups. The lift needed to be refreshed a median of 10 times per case in the saline group, 7.5 times per case in the ORISE Gel group, and 7 times per case for the hyaluronate group. The saline group required significantly more instrument exchanges than both the hyaluronate and the ORISE Gel groups. There were no significant differences noted between the hyaluronate and the ORISE Gel groups' results. The results of the ORISE Gel and hyaluronate groups were significantly better than the saline groups as regards median case length, number of instrument exchanges, volume of lift solution, and number of deep muscle injuries. When the ORISE Gel and hyaluronate groups were compared head-to-head, no significant differences were noted for any of the parameters tracked. These results suggest that ORISE Gel and hyaluronate are equivalent when used to perform ESD in this ex vivo colon model.